So thank you for sticking out all the way till the very end. And my talk will differ in two ways. One is that my slides are very low tech compared to my colleagues here. And the second is I'm going to be talking about ADL limitations following on Dr. Rackow, but how we actually address them to change people's ADL limitations so that they can cost the rest of you less money and have a better quality of life. So this is Mrs. B, and she has just finished a skilled care episode. She was in the hospital because of an exacerbation of congestive heart failure. You've all met someone like Mrs. B. She's got diabetes, arthritis, hypertension. And her exacerbation from congestive heart failure was partly because she can't stand long enough to cook. And she can't get groceries in the house. And so she'll grab, a ramen or some kind of packaged food that she can literally just grab. This is her closet. The reason this is her closet is that she lives in her dining room. She can't get up her stairs. I'm seeing some nods. Some of you have seen this, right? And so she can't even really get dressed because this closet is a sweater bag, and you can see it is safety pinned together, and her arthritic hands can't open them. She spends most of the day sitting in that chair before we got to her. And her floor, this is after we fixed it with healthcare dollars, her floor had holes throughout, which is not that uncommon. If you're an older adult and you've lived the same place a long time and you don't have much money to fix things, your house starts to fall apart. And although we talk about functional limitations costing money, we don't talk about the way the environment affects people's function and about how to change those ADL limitations. But and this is her front stairs. None of us should walk up those front stairs. Certainly not with a shuffling gait and bad balance. So if you think about people like Mrs. B, she'd be happier, we'd all be happier if she could be more functional, and she would save the health system money. But that is completely unaddressed. If you think about what you heard today, sometimes we talked about it as a cost. And Henry Claypool talked about how people like to do for themselves. But in general, we talked about all kinds of case management, but we did not talk about, can someone get their foot over the tub? Can they stand long enough to cook? Can they get dressed? But this is what's costing. It's what older adults care about more than their diseases. It's mostly unaddressed, and it's highly costly. When you look at those people, as Dr. Rackow said, 7 times more likely to be in the high-cost 5% if they have ADL limitations and chronic conditions. So we developed something called Capable, which we are testing now in a CMI Innovations grant and a randomized control trial through NIH. And we developed it with John A. Hartford money and Robert Wood Johnson and NIH money. So a shout out to those investors. Capable focuses directly on people's own functional goals with the idea that if we address those, then they can take care of their medical issues. It's client-directed, not just client-centered. So their goals are not things like, I want to get my hemoglobin A1C to 7. Their goals are things like, I want to be able to get up my stairs so I can sleep in my bed instead of on my couch. Or I want to be able to stand long enough to be able to eat some food so that I don't have to go back to the hospital. Those are the kinds of goals that our participants identify. And they get a handyman, a nurse, and an occupational therapist over 4 months. And you can see the number of visits in the budget. I know we don't have much time. I will just briefly take you through the 4 months. So we collect data at the beginning and at the end and at 12 months. We also have, depending on which trial you're talking about, we have a control group who gets different services. So we will be able to see the difference. And in the CMI Innovations grant, we just have the pre-post, and then they are evaluating the differences. So the occupational therapist starts. And in home health, occupational therapists can't start a case. And so our occupational therapists love this. They get in there, and function is the driver of this model. And that's what occupational therapists do best. So they have an assessment that goes through every single ADL and instrumental ADL, and then the patient themselves prioritize what they care about. Oh, I don't need to work on that. My daughter fills my medication. Oh, I do need to work on that. I can't bathe myself. Nobody wants to be bathed by somebody else. On the second visit, the occupational therapist goes through the whole house and looks at all the areas the person uses and what is causing them to have their limitation. As you know, a limitation is a combination of what the person's qualities are and what the environment throws at them, right? So that if you can give them grab bars and if you can fill in the holes in their seats, sometimes they don't have ADL limitations anymore. So together they fill out a work order for the handyman who starts after the second visit. And that's in the person's priority order. If we disagree with their goals, it doesn't matter. It's their goals, it's their house, it's their life. At the end of the first month, the nurse starts, and the nurse doesn't do anything about adherence or diet or exercise unless it's the person's goals. And so, for example, in Mrs. B, she wanted to be able to stand long enough to make herself some food, so the nurse worked on her arthritic pain and her leg strength. The occupational therapist worked on different cooking tools and ways to conserve energy, and the handyman lowered the kitchen shelves, put in a microwave, gave her a crock pot. These are very simple things, and they're all wrapped around her goals. The nurse and the OT continue through 6 visits for the OT and 4 for the nurse, and they tackle a different goal that the person has at each visit. If they have fewer goals, we stop, but that's the most that they can have. This is just a visual of, 2 85-year-olds live in this house, and you can imagine if you've ever had any leg weakness, you pretty much have to hurl yourself down the stairs if you don't have a banister. And second banisters is the #1 thing that we do that people love. So we have a randomized trial that I mentioned and a CMMI grant. Our preliminary results that I'm about to present have just been accepted by the Journal of the American Geriatric Society, and that's one of the sites on the slide. We are been piloting with our colleagues in the Michigan Medicaid waiver, which we think is a great scale-up opportunity. And we have colleagues in Australia. Australia has been mentioned a couple times today as having great home care packages, as they call it. And we're working over there to see if we can scale it up in Australia. So Capable costs $3,300 for all the 10 visits, the gas, the clinical coordination, the home repair, the home modification. And as you know, nursing homes cost $75,000 a year. So if we can just delay someone by 2 weeks, we've saved money. If we can avert 1 hospitalization for every 5 people we serve, we've saved money. And the participants, as you can imagine, love it. In fact, one of our best outcomes is we're decreasing depression. This is someone who hadn't been down in her basement in a few years before we gave her another banister. So just a few preliminary data points in terms of results. I mentioned depression. Depression is something that the nurse focuses on. And all the little lines are individual people in our study, and the red line is the average. And you can see there are some people who go up, but most people stay the same or go down. And this is solely because they're getting to do what they want to be able to do. It's depressing to sit in a chair all day long. And this is because now they're bathing themselves, they're cooking, they're getting out to go to church. And this is the money slide. On the left-hand axis is the number of ADL difficulties. And so on average, they have a little bit more than 4 when they get into our study. And we have them. We get them down to 2.1 at the end of the 10 visits. And another way of looking at it is that basically 80% improve. And this is low income. These are dually eligible older adults. And this is not mostly after a hospital stay. So you would imagine after a hospital stay, of course you do better. But these are just free-range humans who we, in general, recruit from community centers and from mailings. So these are just people who are high risk because they're out in the community, they have multiple chronic conditions, they have ADL limitations. So it's surprising to improve in 80% of the people. And if you put together improve and stay the same, it's 93% over time for low-income older adults. I will just tell you a brief story about one participant who was on 26 medications, and she sat on a commode chair all day. And she was, as you can imagine, confused and over-medicated. And on our first OT visit, it took her literally 30 minutes to walk to her bathroom, which was short from her bedroom, which was shorter distance than from here to here. She's in a Baltimore row house. And her goal was to be able to get down her stairs and wash her hair in her kitchen sink, which would not be probably anyone's in this room's first goal of what they wanted to do, but that shows you the power of asking people what they want to be able to do. Now, she couldn't come up with that goal on the first day because she was too over-medicated, but the nurse helped her with a medication schedule with just, suns and moons, and I'm sure the kind of thing that a lot of the home care nurses here do. She got her medication straightened out, and then she could start to problem solve about what she wanted to be able to do. And she came up with the idea of putting chairs along the hallway, the kind of plastic chair you might have on a deck, and got herself to increase her stamina to be able to get into her bathroom. And now she does that, and now she can get downstairs and wash her hair. I know I'm out of time, and I think in the discussion we're going to talk about possibilities for scaling up.
Thank you. Now you understand why I called them luminaries, right? So, an impressive group.